All right, thank you, everybody. Welcome once again. The meeting is now being recorded. Just as a reminder, this will be posted on the commission's webpage. Usually takes a few days after the meeting, but it will be posted. This may also be streaming live on TVW. So I will ask Vicki Lowe, who is the chair of the Universal Healthcare Commission, to call our meeting to order.
All right, good afternoon. Can you hear me okay?
I can.
Okay, I'm just making sure. It is now 2:01 and I'm calling the February 13th meeting of the Universal Healthcare Commission to order. I would like to begin with a land acknowledgement. I would like to begin by acknowledging that as we gather today, we are all on the ancestral homes of Indigenous people. For me today, I'm here in Olympia, where the lands of the Squaxin Island and the Nisqually people. Indigenous people, despite being removed from the lands where they lived, hunted, gathered, practiced ceremonies, and cared for their community members. And Indigenous people and tribes, whether they're officially recognized by the United States government or not, continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, of the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington state. As we work to improve health in Washington state, it is imperative that we address the inequities of the past by understanding their impacts of the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you reside. Thank you. And we have a special treat today. We have new Commissioner Patty Cooter has joined us today, and I just want to give her the opportunity to speak to the Commission. Commissioner Cooter.
Thank you, Vicki, and hello, everyone. I am really excited to join you all today and to be a part of what is clearly very important work. It's a priority for me, and it's something that you probably know that I care very deeply about. And I'm really grateful to be here with you, and I'm grateful to all of you for your commitment to this cause. So for me, I believe that healthcare is a human right, and getting to universal coverage is paramount. I also believe it is inevitable. Based on what I've heard around the state, I can tell you that there are many of our fellow Washingtonians that feel that very same way. And I intend to join you at future meetings as much as my schedule will allow. Although I may not be able to stay for the whole time, I promise that I will be very attentive while I am here, and will do my homework and follow up as well. And, I'm really pleased to see the work plan that you've laid out, and the timeline for accomplishing the work is clear. And I'm especially that phased approach of the universal system design work and the transitional steps that help get us there. And I want you to know that we at the OIC and myself personally, we're ready to help in any way that we can, and I hope that you'll see us as a resource. So I look to partnering with you on this very important work, and ready to get going. So thank you so much for the time to introduce myself.
Thank you, Commissioner.
Oops. Sorry, that was my fault. Muscle memory. So thank you for being here. And then we also have the new Healthcare Cost Board and Commissions Director, Ross Valory here. Want to say hi?
Yeah, sure. Thank you very much, Vicki. Ross Valory, the new Cost Board and Commissions Director. Very much looking forward to joining and participating with the commission and with the board. Just a brief background from Michigan originally. So huge Michigan sports fan, Detroit sports fan. So hopefully there's no Ohio State fans participating today. And then attorney by training, and previously worked at the Office of the Insurance Commissioner and Department of Health as a staff attorney. And then went into some policy roles, and most recently came from the Certificate of Need program, managing that program. So very excited to kind of go from the regulatory side to some of this implementation and figuring out specifically echoing Commissioner Cooter's comments about laying out plan design and financing structure for a universal system. So really excited to be here and to work with Mary and Allie and Todd and all the great work they've done. So thank you and look forward to meeting you all in person soon.
Thank you, Ross. And now we can go to a brief overview of the agenda. We'll do roll call first, and then as a reminder, we always incorporate a check-in question to help everybody get to know each other since we've been very virtual. Today's question is, what movie can you rewatch over and over again? And after roll call, we'll vote to approve the December meeting summary and then open the floor to public comments. Following public comments, we'll review the 2025 work plan and hear a report from the January FTAC. After the FTAC update, we'll have our state agency report outs for any updates on the work that aligns with our commission goals. After that, Margaret Smith Issa from the Oregon Health Authority will provide a presentation on reference-based pricing, and we'll have time for Q&A after that. After Margaret's presentation, we'll take our 10-minute break, and when we return, we'll have a rural health roundtable with questions and answers with our rural health panelists. And so now I will turn it over to Mary for roll call. Mary?
Yeah, thank you, Vicki. Good afternoon, everybody. And when I call your name, I'm going to call alphabetically by first name. Vicki's question today to get to know each other better is, what movie can you rewatch over and over again? So I'll start with Chair Vicki.
I am Presence. And the movie that I will always watch over and over again, and usually with my kids and grandkids, is Sandlot.
Thank you. Badisha.
I am here. I think I could watch any of the Mission Impossible movies as many times as possible. Maybe the first one.
Thank you. Charles.
Hi, I'm here, and yeah, for me, it will be Christmas movies as well. Elf or Grinch or any of the classics.
Thank you. Dave.
Hi, everyone. Dave Eisminger here from the Healthcare Authority. I actually have a list that is pre-made in my head. I'll just go with one, though. Fried green tomatoes. I could watch that Tawanda all day long.
Thank you. Jane.
Hi, everyone. Jane Beyer, Office of the Insurance Commissioner. Christmas Eve is Love Actually every year.
Thanks. Joan.
Hi, all. Joan Altman here, representing the Health Benefit Exchange. Good to see everyone. In the battle that has become Christmas versus action movies, I am throwing in on action movies. I've watched the Jason Bourne movies an unhealthy number of times.
Thank you. Representative Joe.
Morning, afternoon, everyone. Lose 12 track of time here. Movies, I like the old spaghetti westerns and all the old Clint Eastwood shows, and I enjoy watching those.
Thanks. Mohammed.
Hello, everyone. Hi, present here. I would say comedy, Step Brothers, but anything that includes Will Ferrell is a good movie for me. I like comedy a lot. Thank you.
Thank you. Nicole. Is Nicole here today? Okay, did I miss you? Nope, we'll go to Omar then.
Hi, everyone. Good to see everyone. Joan, I thought you were going to say Die Hard, whether or not Die Hard was a holiday movie or not. For myself, I'll say The Lord of the Rings. Definitely watch those over the holidays every year.
Okay. And Stella. Is Stella here? Okay, I think that wraps it up, Vicki, and I'm going to turn it back over to you.
Okay. That means So we have a quorum. So if you move to tab 2 in your meeting summary or what's up on the screen, the recording of the last meeting is posted on the commission's web page. We will vote for approval of the December meeting summary now. Is there any discussion of the meeting summary or proposed changes? If there are none,
I would move that we accept the minutes as presented.
thank you, Representative Schmick, and a second from Jane Byer.
I second.
Oh, sorry, was that?
Mohammed, I second.
Thank you, sorry. All right, all those in favor say aye. Aye.
Aye.
Aye.
Any opposed? Say nay. All right, motion approved. Our meeting summary. And so next, I'd like to open the meeting to public comment. All written public comment received since our last meeting is under tab 3 in your book. We have received quite a few written comments from the public since our last meeting. I want to highlight that commission members received these written public comments as part of the full meeting packet last Wednesday, allowing time for review. Individuals can also sign up to provide public comment during the meeting. And I think we have about 4 people signed up so far. And so if you didn't sign up yet, you still want to provide public comment, use the Zoom feature where it says raise your hand at the bottom and click on that so we can find you. Mary will call on you after we hear from those who have signed up. When you are called on, please start by stating your name and any affiliation, who you're representing. We encourage you to focus on the meeting materials, topics that we will be discussing today. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak that wants to speak. You're also welcome to provide comments in writing via email at this time, and especially if you don't get enough time to give us your whole comment. To ensure that everyone has a chance to speak, there's a limit of 90 seconds per person, which may need to be reduced if we get closer to time, and if there's more people then we have time. We will be displaying a timer as a reminder of the limit, and when the timer stops, please complete your comments. Thank you. All right, Mary, would you like to start with the names of the individuals who signed up for public comment?
Sure. Thank you, Vicki. The first person who signed up is named Andy Song. I'm not sure if Andy's attending in person or has logged in.
They're not here in person.
Okay, I do not see Andy's name. So I think we will go to the second person and we will keep an eye out to see if Andy is here. Unless that's the hand that's raised. Okay, so the second person who had signed up ahead of time is David Loud. Is David here?
Yes, I am here. I am here.
Hi. Hello.
Okay, thank you. Commissioners, first, I want to appreciate your hard work and the importance of the work that you're doing. And I represent Puget Sound Advocates for Retirement Action and also the Healthcare is a Human Right Coalition, in which I represent Pizarra. And I want to express my frustration today about the role of public comments and how the commission has been able to deal with public comments. Last month, or at the last meeting on December 5th, I made a public comment and I tucked it into the written form as well. And what I pointed out is that although the milestone tracker makes it appear that eligibility as an issue under the design of the Universal Health Program appears completed, it has not been completed. And that was the subject of my comments. It's in the packet for today. And there are a number of points. The one that I want to emphasize most is that in the October meeting, I heard it said that veterans would not be eligible for the state system because they have the VA. But only a minority of veterans use the VA system. And even for those who do use the VA system, some are not eligible for all VA services and must also rely on other sources of care. So I believe the universal system that you're designing should welcome any veteran who elects to use it. And so I don't understand how something I pointed out, which is, I believe, quite accurate, isn't reflected in the tracker. The tracker still shows eligibility to be completed. So anyway, that's my comment, and I hope that you will pay attention to it. Thank you.
Thank you. The next person who contacted us ahead of time is Consuelo Echeverria.
Can you hear me now?
Yes, yes, we can. Welcome.
Okay. Yeah, a little bit of technology here. As with David, thank you so much, commissioners, for your work here. It's very difficult. Systems change, especially, is very difficult. And as we finally move into the issue of governance, I would like to remind the commissioners that they do not have to reinvent the wheel. There are 78 countries that have universal healthcare systems, and 17 of them are single payer, meaning that everyone can access quality health services without financial hardship. And considering that medical debt is a leading cause of bankruptcy in the United States, a single payer universal healthcare model is essential, and I would like the commissioners to please not forget that. Additionally, I would like to point out the work that's been done in Washington State with the Universal Healthcare Work Group final report of 2021, which has a detailed financial analysis as well, and the whole Washington bills of 5233 and 1445, which also lay out a roadmap including governance for single payer. And finally, in my remaining seconds, if you get the time, do check out Wendell Potter's Substack. Rural Electric Co-ops can teach us about fixing healthcare. It's excellent. Well, I slipped in right under the.
Thank you. All right, thank you. Our next person who has signed up is Peter Marcus, and I should add, and I should have added this at the beginning, that as we are moving people over to accept the panelist link, there is a little bit of a delay, couple seconds. Also, we have some staff members under the weather, so we have some pinch hitters today, so it may take a few extra seconds. So we appreciate your patience on that one. And our next speaker is Peter Marcus.
Hi, yeah, I'm Peter Marcus. I'm a voter in the 31st Legislative District, Pierce County, and also I work with Whole Washington. And I would just like to read what I mailed in as a public comment. Thank you for providing the milestone tracker chart in the meeting materials. It provides meeting participants a good review of what the necessary tasks are and how much progress has been made toward their completion. I highly recommend discussing the chart and the progress made at the beginning of each meeting, which I see that you're going to be doing at this meeting. Thank you very much. Also, I recommend assigning planned completion dates to each of the phases, not just to phase one, as is presently shown. And better yet, consider assigning dates to each of the milestones. And as David Loud mentioned, there's some concern about the eligibility milestone. And I was wondering if there was a report or a record of decision that showed the output of the completed milestone eligibility. And yeah, I just second what David had to say about the eligibility of veterans. It's possible that there are some veterans that aren't covered by the VA health system, and we wouldn't want those folks to fall through the cracks. Thank you.
Thank you. I'm looking again, wondering if Andy Song has joined us. Andy signed up ahead of time, so I'm taking one more look. If you're here, Andy, please put your hand up and we'll find you fast. And I don't think Andy is here, but we do have a hand up, and it's Catherine Lewandowski.
Hi, can you guys hear me?
Yes, we can.
Okay. Thank you, Chair Lowe and members of the Universal Healthcare Commission for allowing me to give public comments today, and for all the work that you do. We really appreciate it. I'm a retired registered nurse and I'm the board vice chair of Whole Washington. Boy, has it been just a whirlwind of a year so far. I feel like it's going to be quite the ride in 2025. Every day I feel like I am 2 days behind. This is not really how I imagined retirement to be. I want to share my experience last night at a great Seattle Town Hall event that I had the pleasure of attending. The title was Capitalism in Healthcare. The facilitator was amazing and also were the panelists who were present. My heart went out to the disabled panelist who is disabled as an adult, and her having to share that in order for her to get the care she needed just to get through daily life required her to spend down everything she owned and had worked for in order to be able to get any caregiving benefits that she needed to survive. There was a lot of discussion about how we seem to not really have a healthcare system here in America, and rather we have a system of sick care where once people lose their health, they then become a profit center for hospitals, insurance companies, and others to create profit for their companies. And is that okay? Most of the people in the attendance felt that no, it was not okay. An epiphany that I had last night and that I shared at the town hall, I think it was well received, was that there are many other ways in a capitalist economy to create profit. Having the financial ability to travel creates profits, to be able to eat well, to be able to pay down the rent, to buy a nice home. These are all that we can create ways we can create profits for corporations, and is putting a person's earned income back into their pocket a better way for us to be able to enjoy the fruits of our existence. It seems to be much more sustainable way to fortify our capitalist economy. We already know what moral choices are available. It's time to imagine ourselves choosing the moral choices that will benefit everyone. And it's time for us to imagine putting one foot in front and stepping out in front of the pack who are afraid and say it is not possible. It can't be done in America. And step into that group who says, we can do this. We can make this happen for our children and our neighbors. Thank you very much.
Is there anyone else, Mary?
Mary, you're muted.
Thanks, Allie. I was saying I do see one hand raised. Bryn?
Hello, commission members. My name is Bryn Friel. I'm a member of Washington CAN and a federally disabled small business owner in Anacortes. The shortcomings of healthcare coverage have deeply affected my life. Before age 21, I'd gone through 2 lifetime limits in commercial insurance. I was completely uninsurable until the ACA. And while the ACA saved my life, I still went through a medical bankruptcy. We know the ACAs help the most vulnerable in our communities, but changes in market rules have led insurers to pull out en masse from state markets. This is now happening in our state, county by county. I moved mid-year from Snohomish to Skagit County in 2021 and lost the insurer that covered my continuing treatments. Prompt attention to governance is essential to avoiding these types of pitfalls. Healthcare governance provides the pillars and foundations advocates have been calling this commission to establish for years. Good governance ensures policies and protocols are uniformly applied, that risks are identified, assessed, and controlled, that evidence-based clinical protocol is followed, leading to positive outcomes for and reducing risks to patients and providers while helping guide financing and payment. I'll leave you with a final thought. My father worked as a builder. In building, you can't install plumbing and appliances before the foundation is poured and the frame is up. The only way to achieve successful administrative simplicity and cost efficiency in a truly accessible single-payer system critically depends on governance. Please address this far sooner than it is currently laid out in the work plan. Thank you.
Thank you. And I'm not seeing any other hands raised. I don't think Andy has joined us. So Vicky, I turn it back to you.
Right, thank you, Mary. Thank everybody for their comments. And now we will hear a work plan update from Mary. So I guess back to you, Mary.
Yes, it's back to me now. Good afternoon, everybody. Audrey, we can go to the next slide. This is the work plan update. We, have been updating our graphics and our plans, and we like to just frame this up every meeting, get started with an update on where we are. So if we could see the next slide. This is an image that we've seen that some folks commented on today, where we are in the universal system design, also the transitional solutions and the legislative reports. This has looked the same pretty much since November, so this is very similar to what you saw in December. Next slide. Some of our speakers today talked about eligibility and questioned eligibility and asked about why it's green in the previous slide. And so we wanted to address that. In 2024, the Commission determined eligibility in order to establish the foundation for the other phase 1 decision points. And the phase 1 in the previous slide is the green eligibility and the other 3 yellow ovals. And what was determined was the people who are most likely to be included in the universal system with the uniform financing. And this is, I think Vicky put it the best way the other day. She said this is where the state has more of a say. So in the initial phase, these are the people most likely to be covered by the universal system, and it's people currently covered by Medicaid, health plans, the fully insured group health plans, both small and large employers, PEB-SEB plans, public employee benefits, school employee benefits, and people who are currently uninsured. So that, Vicky, you about to say something?
Yeah, and I would say that, to Mr. Loud's comments that the veterans would likely fall under the uninsured population if they don't have any other form of coverage, because like Indian Health Services, the Veterans Administration is access to care. It's a system of care. It's not a coverage.
Okay, thank you. And Audrey, if we could go to the next slide. At our last commission meeting, we talked about the 2025 goals. And what we heard from the commission is that it would be good to spend the first portion of this year more focused on universal design, the second half of the year, bring back the ideas of the transitional and the interim solution. And it's not that the interim solutions are going away. This was more a recognition that there's a tremendous amount of change right now in the state legislature, state agency head, state governor, federal level. I think it's, a bit of an understatement just to say a lot of change right now. It's pretty overwhelming for a lot of people, and that it might make more sense to focus on the universal design initially, let the session and the budget shake out, and then pick up the interim solutions in the second half of the year. Jane.
Thanks, Mary. So the only thing I totally understand the logic behind this. I probably voted for it, but the one thing I would ask folks to keep in mind is that if any of the transitional or interim solutions that the commission comes up with would require legislative change, to think about how we prioritize anything that we put together on those, because getting something to the legislature at the end of December that would require legislative action in the upcoming session, especially a short session, as we're going to have next year, can really be a challenge. So I would suggest if we're thinking about transitional, think about whether they would require legislative change or funding, and try to prioritize the ones that would require either.
Thank you. Yes. And we will note that as we are, in fact, maybe it'd be good to look at the next slide right now. And we'll get to the second half of the year, Jane, which is part of what I'm responding to. But if you look at this now, this is how we see ourselves stepping through the priorities of the first half of the year. Right now, we have the cost containment. Initially, we had benefits and services prioritization a little sooner in the year. That depends largely on some work that is being done right now by Milliman that I know David's going to talk about a little bit later. That is some cost modeling that really will inform the benefit and service prioritization discussion. That report, that body of work from Milliman, will be made available to FTAC in March, which is why benefits and services got pushed into the future. And so there's some color coding going on here that once something is orange, that's a preliminary recommendation to the commission. So we're hoping the next meeting, preliminary recommendation of benefits and services, cost containment, feedback to FTAC in May. And then when it comes back to the commission in June, it's in red because we're hoping to adopt the final recommendations on those two topics. The next slide, Audrey. So here we are in the second half of the year. We're following a very similar pattern of things going back and forth and moving from orange to red and moving from FTAC to the commission with different topics. And then August is where we pick up again, preliminary recommendation, prior authorization. And that is, we're picking up the interim solutions again. And thank you, Jane. We will keep that in mind as we are ordering, your comments in mind, ordering what is considered when. And November and December just says future topics. That's because we know that topics will slide into November and December, and we also know that things will come up during the year. And it's a little hard to predict them at this moment, but we know the work is there. So those are our just reminders that the work will go on. And the next slide. Oh, and that was my last slide. So thank you, Vicki. It's back to you.
Thank you, Mary. Before we move on to our update from the FTAC, I did want to share that Pam McEwen has stepped back from being the liaison from the Financial Technical Advisory Committee. I was just explaining earlier that my New Year's resolution is not to use acronyms, and it's very painful. So Pam is going to stay on the Financial Technical Advisory Committee. And David Di Giuseppe has agreed to take her seat as our liaison to the commission. So we're welcoming David here today to give his first update. So we want to give a lot of thanks to Pam for, starting out with the being our liaison. I know she went into retirement and then started working on that. So we appreciate the time and we appreciate David stepping into her place. So thank you.
Well, thank you. Yeah, big shoes to fill for sure. Mary, can you hear me okay?
Yep, you sound good. I know that room's tough.
All right, great. Audrey, do you mind going to the next slide? And the next one, please. So this is what we will cover today. Our meetings at FTAC, or the Finance Technical Advisory Committee, start out similar to this, where we have public comment. 3 comments were brought up at that meeting. The whole Washington group pointed out to us the revised bill that's been submitted for this session. One of the speakers, similar to today, urged adoption of a single-payer system. And we had a comment similar to what you've heard today about urging us to concentrate on establishing governance, which is currently planned for phase 3. You can see the rest of what I'm going to talk about. We have slides for each of these, so we can go to the next slide, please. As you heard Mary say, Milliman has been working on their analysis, and there are 3 of us who serve on FTAC that also are liaisons between FTAC and the Milliman team. So we've been meeting monthly, is it, Mary? Every 2 weeks. Yeah, we meet
every 2 weeks, although we somehow managed to schedule a lot of things on holidays, so maybe it's been more like monthly in practice.
So as you heard Mary say, HCA is getting a review of Milliman's analysis, and then Those of us who sit on FTAC will see that in March with the idea of presenting the results to you in April. We've worked very thoughtfully with the Milliman Group and are looking forward to the analysis. The results will be broken out in a way that I think will help us answer or address the questions that Mary described, both on the incremental expense of going from the baseline situation to covering new populations, as well as looking at differentials in costs across different benefit designs and cost sharing schemes. Next slide, please. A representative from the Healthcare Cost Transparency Board presented to us. The big picture result is that spending increased slightly above target at 3.6%, moving from 2021 to 2022. That was driven by the Medicare market. The other markets besides Medicare came in at a lower trend than that. Those of us on the FTAC group expressed interest that we continue to be apprised of what the Transparency Board is doing and looking for overlap between our committees and areas where we underscore each other's work. In your packet, there is a link to the presentation in case you're interested in watching that yourselves. Next slide, please. We had a fantastic presentation from one of my fellow committee members, Bob Murray. Hi, Bob, I see you on the screen here today. Bob presented to us on the topic of flexible hospital global budgets. You've probably heard of the hospital global budget idea, and Bob has conceived of a particular idea that he calls the flexible hospital global budget. The flex portion of that means that you cover the fixed costs of a hospital, and then you set up a pricing model whereby you cover the marginal cost of each additional unit of care that a hospital delivers, such that if a hospital's volume goes down, they're only losing the marginal revenue, but their fixed costs are covered. And if the volume goes up, they receive more money to cover the additional cost of that additional utilization that they provide. Bob pointed out one of the attractive features of this model is that the state does have the legal authority to set control budgets and monitor affordability or achieve affordability goals through a mechanism like this. And Bob's model in particular, which I spent a fair bit of time looking at, is lower intensity than something like you've probably heard about, which is the Maryland model, which is a fixed hospital global budget model. And we FTAC encourage any of you to watch Bob's presentation. Bob is a national expert, came from Maryland, has a compelling presentation behind the concept, why it makes sense. And in fact, we at FTAC would urge the commission to invite Bob to present to the commission at some future date. Next slide, please. We heard about reference-based pricing and discussed that topic, and you're going to hear about that today. One of the thoughts that we had is that may be a nice interim step on the way to a hospital global budget in terms of being more politically feasible and less disruptive than a hospital global budget. We also had discussion, and some members of FTAC felt it would be meaningful for you as the commission to formally endorse the bills that are being debated around implementing reference-based pricing. At the same time, we do acknowledge that you did have a discussion about this previously and decided to take a more general approach. Next slide, please. We are going to address the issue of cost containment, the various levers that are available from a finance technical perspective, and then we'll move on to discussing benefits and services as Mary described. Our next meeting is March 13th, 2 to 4:30 p.m. And of course, that's open to the public. That is the end of my report. Does anybody have any questions about that?
David, I see Jane's hand up.
Hey, David, thanks for that. So quick question. In terms of the menu of things that the FTAC is looking at for cost containment, Are there specific policies beyond global budgets and reference-based pricing that you're looking at?
Yes, so we're in the process with the help from the staff at HCA of compiling a comprehensive list of cost containment levers that have been used in the current system that have been considered elsewhere, including reference-based pricing and hospital global budgets, but not limited to those two things.
Great, thanks. That's good to hear.
And I want to thank Mr. Murray for the presentation. I hope all of you got a chance to watch it. It was really very informative, and thinking of it in terms of the rural healthcare conversation we're going to have too, because I do come from a rural area, and I do know that our hospitals, I've talked to our hospital administrator about global budgets and scared him a little bit, I think. So I do, it was really helpful to have better knowledge about it. So I really encourage everybody to watch that video at least. Are there any questions or comments, commissioners?
I'll just add one comment if I can.
Okay.
Yeah. There was a slide within David's deck talking about the schedule for the Milliman report. I think in one of the bullet points was, you know, the first iteration that has not been fully vetted, you know, the HCA, there we go, the HCA only. That is on schedule. That meeting of HCA seeing the initial non-public report has happened. We are working back and forth with Milliman. And I wanted to just clarify very briefly the structure of what Milliman is doing. What FTAC requested was to take some existing benefit scenarios and, you know, do some cost modeling of applying those existing scenarios to the population that is likely to be covered. So it's existing benefits, selected population, and what might that look like? And the reason I want to clarify this is not anything that has been recommended by anyone. I mean, it's not like this is an endorsed plan that we are trying, this is just a process of what would this cost as a starting point for FTAC to start turning knobs and, you know, getting a sense of what things would cost. Not, this is an FTAC endorsed proposal that they're sending, because they haven't gotten to that point yet. I just wanted to make it clear that the universe is still wide open. This Milliman analysis is an attempt to get some idea so we can begin to narrow that universe.
And Mary, remind us of it was 3 plans that they were.
It's 3. It's Medicaid, it's PEBSEB, and Cascade Select.
Thank you.
Unless I got the wrong one, Allie, is that what it is?
That's right. Yeah.
Okay.
So any questions? Okay. Thank you, David. Thanks for being here too.
Yeah.
Even in the snow. We're going to move on to our member report outs. Oh, Mohammed, I'm so sorry. Go ahead.
Yeah, sorry, I was struggling to raise it. It's not working for me for some reason. No, I just wanted to say the commissioners encouraging legislators to pass or look at the bills. What would that look from the commission's perspective, especially those in the commission who are not elected?
Right. And I think that was our conversation last time, was that the people who are commissioners and agency staff are in kind of a sticky situation when we do that. I think did we talk about this? I've had a lot of conversations, but in our own capacity as Washington State citizens, we're able to really endorse bills. But I think did you guys look at the fiscal note for that reference-based pricing bill? Because it's $1 billion savings in the first 4 years and about $2 billion in the 6 years that they put on the fiscal note. And I think I would love to see us endorse it, but I don't want to put our agency staffers who are commissioners in a difficult situation. I think that when we talked about before, also the legislators said that they can't really be a part of that either. So I don't know, anybody have any comments on that? Am I remembering right?
Yeah, I would note, Vicki, that since the new commissioner has come in, OIC is actively supporting the HCA reference-based pricing proposal.
Oh, okay. Then HCA probably is too, huh?
And then I would say
The
Chair
exchanges
Vicky,
too, so.
All right. So
and I would say, Chair Vicky, that agencies in general are neutral on legislation and providing technical support, except in the instance where it's agency request legislation, in which case we can actively support. And the bill by HCA about PEBSEV reference pricing is an agency request legislation, so we could be very affirmatively supportive of a bill that has that agency request designation.
okay, well, I'm gonna veer off agenda and ask if somebody wants to make a motion about commission support of the PEBSEV reference-based pricing bill, whose number I can't remember off the top of my head.
House Bill 1123, Senate Bill 5080.
Thank you. Does anybody want to make a motion?
I will make the motion that the commission support Senate Bill 5083 and House Bill 1123 as amended in committee, because both of those bills have virtually the same amendments that adopted. 5083 moved out of the Senate Health and Long-Term Care Committee, and 1123, I think, has 1123 moved out of approps yet?
1123?
Think.
Yes,
Yeah, okay.
it has.
Yeah. And they both have, I think, very similar amendments to clarify the provisions of the bill.
And just, clarification, how do we want to support it? I guess write a letter to the health committees, write a letter, sign in pro, give testimony.
I mean, I would think, Vicki, you as chair of the commission could testify pro. The commission could submit a letter of support. I know that, especially in the fiscal committee, so the Senate bill, I'm assuming, has been referred to Ways and Means. Time can get really, really tight, especially, during these, as we get closer and closer to cutoff. So I think if you were going to testify for the commission, it would be, we're lucky if you get 60 seconds.
We could do written testimony.
Right.
Okay. So maybe directing staff to work on written testimony, and we can either do a letter or written testimony to make sure we get our point across. I really 60 seconds for testimony is frustrating, realizing that we give 90 seconds. But I think written testimony can sometimes be as impactful as so I'm sorry, I'm trying to amend your motion, Jane. Representative Schmick.
Thank you. The commission can do whatever they would like. I just need to be excluded from that.
We will note that the legislators are abstaining. Any other discussion?
And just a question, Vicki, you're going to make a motion to amend, and you would like commission staff to draft a letter, or not a letter, written testimony for you for presentation. Okay, thank you.
Okay, probably right.
Oh, no,
We can
no,
do it together.
we would be happy. Yeah.
Sorry. We should be directing you guys. So we have a motion and a friendly amendment. And maybe what Ross just said, did that sound like the right amendment that will write testimony to support Senate Bill 5083 and House Bill 1123 to be submitted during the hearing? Is that okay, Jane? We need a second for the amendment.
I believe I'm in a position to make the second.
All right. All right, all those in favor say aye.
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 Opposed? Sorry. Opposed, say nay. Abstaining, say aye. For the record.
I will abstain.
There. All right, okay, sorry for going off agenda there. Great, so we were on our member report outs, and looks like our list is alphabetical by first name, just so Dr. Chima heads up. You're first again. We'll have our state agency representatives give report outs on updates on work they're doing that aligns with the commission work. So Dr. Chima.
Yeah, thank you. Not a lot of specific updates to give today, but session is very much in progress. Hundreds of bills that have health impact. The agency has reviewed and continues to review. So as I said, things are moving as expected. And we're still in the transitional period with an interim secretary, and I believe a process has been initiated by the governor's office for the permanent secretary for health. So just looking to continue to work through this transitional period and welcoming the new secretary when that is appointed. But other than that, I think priority right now is complying along with other state agencies in going through the budget reduction exercise to help the state balance and address the budget deficit. So that has been a lot of the priority over the last few weeks, is really working to meet the governor. So collaborating with the governor's office and OFM to figure out where we can find those savings to really balance the budget and get things in a more sustainable way. So that's been sort of what's been priority across many state agencies in the last few weeks, and working through the transition as well. Thank you.
Thank you. Yeah, it's rough, I think, at all the agencies right now on that, and a lot of sympathy to you, Representative Schmidt. I think you're doing hard work there too on the budget. Next up is Dave, Healthcare Authority.
Sure. Hi, everyone. At the Healthcare Authority, I think since our last meeting, it's important to say that we have an interim director, Mary Ann Lindeblad, who many people are familiar with, as she served for many years as the state Medicaid director, and then earlier in her career history was the PEB director. So she is our interim director, while similar to DOH, that the governor's office continues its search for the permanent director of the agency. There's hundreds of bills being monitored by the agency for a variety of different ways. We have several pieces of agency request legislation, one of which was the reference-based pricing bill that was just spoken about. And those agency request legislations are generally on their journey. I think the reference-based pricing one is the one that is probably most relevant for this commission. So I appreciate everyone leaning in on being able to offer commission support on that. As was highlighted a moment ago, Healthcare Authority is an agency of the executive branch, also working through the exercise of budget reduction as options for the governor's office. I believe there was a press release earlier today that highlighted generally 6% admin reductions being targeted for agencies. The Healthcare Authority was included in that. And so just for proxy for folks, that's about $535 million. And so that type of that's a very large amount for this agency and any agency, a 6% cut. But just the magnitude of that for folks' awareness, wanted to highlight that. So those are the types of things we're working on here.
Dave. Jane, the OIC.
Okey doke. So first of all, my heart goes out to Dave and to everybody else who's having to go through the budget cut exercise. Because OIC is not a general fund state funded agency, our agency is funded by surcharges on all of the insurers, all types of insurers that offer insurance in the state. We do not have to go through that budget exercise. So, but I did it twice before when I was in the executive branch, and there was nothing fun about it. So in terms of bills that we've been really focused on that relate to the work of the commission, we are happy to report that Senate Bill 5084 passed the Senate and is on its way over to the House. This is the bill that allows us to require health insurers to tell us how much they're spending on primary care, and to do it in the same way that the Healthcare Authority requires reporting for the PEV and SEV programs and for the Medicaid programs, because we are all mindful of the goal of increasing primary care spending in the state to 12% of total expenditures. So this will give us an opportunity to get the same kind of information for commercial health plans. House Bill 1686 is a bill sponsored by Representative Bernofsky to require reporting of ownership and affiliation by health insurers and healthcare facilities and health systems. And one of the big findings of the preliminary affordability report that we put out was that we wanted to present a picture of the structure of the healthcare insurance and delivery system in Washington state, but we couldn't provide a full picture because we didn't have a whole bunch of information about ownership and affiliation. So that bill would get that going. We testified in support of a corporate practice of medicine bill that Senator Robinson is sponsoring to try to get a better sense of not having private equity firms be able to control the clinical decisions of providers. Again, reference-based pricing. The Senate Health and Long-Term Care Committee this morning moved out Senate Bill 5075, which prohibits cost sharing for prenatal and postnatal services for commercial health plans. We are very, very, very mindful of the disparities in maternal morbidity and mortality. And so this is based on a recommendation that OIC made to the legislature last summer. We're hoping that if people do not have to pay cost sharing for prenatal visits and postpartum services, that'll be one less barrier to receiving those services and trying to get at the really horrible disparities that we have on maternal outcomes. And then I'll just quickly mention that there's legislation moving, or at least under consideration. It's House Bill 1432, and it relates to access to behavioral health services and behavioral health parity, and our agency is supporting that. And then the final thing I'll note is we are working with Senator Slatter and Representative Tai to try to increase funding for our Senior Health Insurance Benefits Advisor program. We all know that the states cannot regulate Medicare Advantage plans. There's a federal law that says we can't, but yet we all hear concerns from seniors about their Medicare Advantage plans. So at a minimum, what we want to do is try to be much more aggressive about getting seniors information they need and providing unbiased counseling on Medicare enrollment and Medicare complaint resolution issues. So those are the big ones.
Thank you, Jane. Joan, the exchange.
Cal, happy to give a quick report out. I think since the last time we spoke, we were in open enrollment. Last time I was in front of you all, and we had a record-breaking season this year in terms of signups. The exchange, we sort of broke 300,000 people enrolling on the individual market for the first time. A combination of people turning off of Medicaid, sort of in a continuation of the unwind activities, and also the availability of federal and state subsidies that are helping mitigate some of the cost increases we've seen year over year in the individual market. Some things on the horizon that we're mindful of, the enhanced federal premium tax credits that have improved affordability over the last few years, federal assistance to people to buy health insurance on the exchange increased, sort of bumped up during COVID, and they're set to expire at the end of plan year 2025. So I think actuaries have estimated about 80,000 people may lose coverage when those federal subsidies, if those federal subsidies expire. So working with our federal delegation to understand those potential impacts. And then at the state level, the need for Cascade Care savings in our state federal subsidy was so high that we had to sort of shut off that program toward the end of open enrollment. So there's an ask into the legislature this year to look at increasing funding for that program, knowing that it's a significant general fund state ask in a constrained budget environment. The other thing that we delivered to the legislature since last time we chatted was our auto enrollment study. There was an ask from the legislature to look at ways we could facilitate people navigating off of Medicaid and on to qualified health plan coverage. That was also of interest as a transitional solution to this committee. Our colleagues over at DSHS did a really nice analysis, and happy to share the link if of interest or have them come speak to it further with this group. They tracked people, everyone who turned off Medicaid in 2019 as a baseline year. They also looked at everyone turning off of Medicaid in 2023 and sort of coordinated all their data sources to find out how many of those people were potentially uninsured. And it was, in 2023, that number was nearly 100,000 people. And then when you look at who's falling into the potentially uninsured bucket versus who is navigating their way over to qualified health plan coverage, unsurprisingly, people who, American Indian, Alaska Native, people who attest as Black and Hispanic, overrepresented in the uninsured group and underrepresented in the qualified health plan group. So, looking at ways we could help facilitate coverage or help people as they're leaving Medicaid get connected to affordable qualified health plan coverage. We're also what's things that are on our mind with regard to the federal authorizing environment right now, in addition to the loss of the enhanced premium tax credits, looking at regulatory changes that might be coming that could impact access to the individual market or access to Medicaid in a way that would involve Health Plan Finder. We're also looking at watching for potential federal engagement that would impact some of the immigrant health expansions that have been done over the past couple of years, and looking for changes that would sort of impact our immigrant communities who are getting coverage. There are about 2,000 people getting covered through a federal waiver right now that could garner some attention, and in which case working with colleagues over at Healthcare Authority and OIC and otherwise on potential ways to maintain a coverage pathway for people who might lose access to it under the waiver. So that's some what's on our mind here. Happy to take questions.
And for the Medicaid program, the 90% FMAP for Medicaid claims, does the federal FMAP, does that end at the end of this calendar year as well? Are those all For some reason, I thought with the Affordable Care Act at the end of 2025, that federal match goes down.
Dave, we'll defer to you on any other changes to the FMAP. I know we're looking at potential changes to the Medicaid reimbursement rates more globally. Also looking at potential changes in indexing to the federal tax credit, but we'll defer to you on when the FMAP might slide back down.
And Chair Vicky, I'm not exactly sure if it aligns with the federal fiscal year or if it's on a calendar year basis. So I would only be opining, and this is not a place to opine on something of that nature. So we can follow up with the exact detail.
Okay, thank you. I think it would be good to understand you said DSHS was doing the churn report?
Yeah, happy to share. Dave Mancuso did a great deep dive for us. We sort of combined our data with DSHS data, and they did a really robust look at the people turning off Medicaid, and who sort of ends up on qualified health plan coverage and who ends up going back to Medicaid and who ends up potentially getting employer coverage and then who ends up potentially uninsured. So good look at where there may be some coverage gaps. So again, yeah, Chair, happy to follow up with you and HCA staff if it's of interest and share some of those findings.
Yeah, I guess so. Do the lead orgs then kind of take that information and try and focus their efforts with navigators?
Yeah, we've been sending out for folks since the unwind began. The exchange has been sort of generating data-driven reports of people who are turning off, and then if they do not regain Medicaid coverage, having our assister networks and our outreach and marketing efforts targeted in those areas. And it's something that we saw increase. So, between 2013 and 2023, with some legislature assisted funding as well, we sort of were able to enhance our outreach and sort of data-driven marketing strategies, and we saw the numbers go up and we saw the disparities go down. So we know some focused and targeted outreach helps move the dial. The report sort of highlighted the other side of that dial, the people who were not reaching through those efforts, who are likely not getting covered.
Thanks, Joan.
Sure.
And then Omar, Office of Equity. Do you have anything to report?
No, nothing specifically. I will say though, I appreciate the bills that were mentioned earlier, and I think just speaking from agency's perspective, if there are bills that agency partners are wanting additional support in, please feel free to reach out. I think being executive cabinet, we're able to more streamline the support, and so please, if we can assist with getting the voice out or anything on certain bills that you're tracking, happy to assist.
Is there anyone else that would like to provide an update? Or other commissioners? Great, thank you for everything that you shared. So next, we're going to move on to a presentation on reference-based pricing. So very timely by Margaret Smith Issa of the Oregon Health Authority. Following the presentation, there'll be some question and answers. Margaret, are you ready?
I am ready to go. Thank you so much for having me this afternoon. Good afternoon. I'm glad to be here. As mentioned, my name is Margaret Smith Issa. I'm a program specialist with the Oregon Health Authority, specifically with the Oregon Public Employees Benefit Board and the Oregon Educators Benefit Board. And as I'm sure most of you are likely aware, for the state employee health plan programs in Oregon, we implemented several years back a Medicare benchmarked reference price for inpatient and outpatient hospital services. So I'm here to share with you today just a little bit of information, some background about what the policy is and our experience with it to date. And as noted, hope to leave ample time for any questions you might have at the end. So we'll go ahead and get started. If you could, thank you. Yeah, next slide, if you could advance, thank you. Just in terms of a quick overview to kind of cover what I have included today, I have a little background on kind of who we are, Oregon State Employee Health Plans. A very brief amount of data on just sort of the challenges sort of behind this issue. It's information I think all of you are, will probably sound very familiar to all of you in terms of the cost growth and payment variation dynamics. And then I'll talk specifically about Senate Bill 1067, which is the bill that was passed in the Oregon legislature back in 2017 to establish this limit on our hospital payments. And then I have some information on the savings we've realized, impact, and general considerations. Next slide. So to start off, just to kind of talk about who we are. So Oregon's public employee health plans include both the Oregon Educators Benefit Board and the Public Employees Benefit Board. Both programs sit within the Oregon Health Authority. The programs share an executive director and staff, but have two separate and distinct boards that govern the benefit programs. OEB, the Educators Board, as we call it, provides benefits for over 240 school districts and community colleges across the state. PEB, the Public Employees Benefit Board, provides benefits for over 200 state agencies and universities within the Oregon university system throughout the state. Additionally, per statutory language that was passed several years back, city and county and local government jurisdictions across the state have the option to opt into either PEB or OEB if they would like to receive their employee benefits through either program. And to date, those local jurisdictions, local governments represent about 3% of our total enrollment, and that's a segment that's growing. But all said, PEB and OEB together each have about 150,000 covered lives, so 300,000 people total, which represents about 15% of Oregon's commercially insured. Next slide. In terms of just a little bit of kind of context around the aims of OEB and PEB, or our goals, the boards really strive to provide comprehensive, high-quality benefits to the agencies, universities, school districts, local government entities, that participate in the pools. They strive to really ensure the benefit plans promote prevention, support employee health, and advance health equity, and also really work deliberately to manage the costs so that the benefit plans are affordable to employees and also to the employer groups that purchase plans through our pools. Next slide. So here's a little bit of the high level data I'll talk about. And I mentioned this is certainly going to be, I think, familiar to a lot of you, this general concept. And this is looking back. So when we look back, and this data goes back sort of prior to 2017. But for a number of years, prior to the passage of this legislation, we observed the phenomena where, the annual change in total health benefit costs per employee outpaced worker earnings and overall inflation for the vast majority of years as you look back historically. And this, this creates ongoing challenges in terms of how to continue to provide comprehensive benefits that provide good coverage to employees in a climate where the costs of doing that outpace cost growth in other areas. Next slide. In addition, when we really kind of tried to dig into some of the cost drivers in the mid 2010s around, what was driving plan cost increases, hospital unit cost was often identified in those analyses as one component of costs that had increases that significantly outpaced inflation at the time. And additionally, when we looked at costs across hospitals, and in particular, the data on this slide is looking at large hospitals for PEB and OEB expenditures, and this is data from 2017. We certainly noticed a fair amount of variation in terms of the level of payment for those hospitals. You can see on this slide, on the inpatient side of hospital services, we observed, range payments in the range of 185 to 340% of Medicare. On the outpatient side, 215% to 375% of Medicare in terms of the range in payment variation. And this range, the variation really wasn't linked to any sort of difference in outcomes or quality or sort of any discernible reason we could identify for the difference. Next slide. So all of this kind of background data, it informs kind of, I think, where the direction that policy goes. And ultimately, in 2017, as I mentioned, Senate Bill 1067 was passed by the legislature, and it was a fairly large bill that included a number of different provisions. Two major ones included in the bill related to public employee health benefit costs. One of those provisions was that the bill established a 3.4% limit on the annual cost growth for OEB and PEB benefit plans, and that was annual total medical expenditure growth as well as premium growth. And then the second provision included in 1067 was a limit on the amount that insurers and third-party administrators that contract with OEB and PEB can pay for inpatient and outpatient hospital services. So for the remainder of these slides, I'm really going to focus on that second bullet point in terms of the limit on hospital payments and share some more specific details around that. So that specific provision in the legislation limited PEB and OEB insurers and TPAs, prohibited them from paying more than twice the amount Medicare would pay for an inpatient and outpatient service claim at network hospitals. It specifically set a lower limit for non-network facilities. So that limit was set at 185% of what Medicare would pay. The statutory language applies to hospital services only. So it does not include professional fees for services delivered in a hospital setting. Additionally, legislative action was taken to specify that the limit does not apply to out-of-state hospital services. And that actually happened in subsequent legislation. House Bill 2266 in 2019 added language that specified that it applies only to hospitals in Oregon. And we do have a percentage of services, certainly for our members, that is delivered in out-of-state hospitals. In addition, the legislation specified that hospitals paid in accordance with the limit may not balance bill. And it also laid out criteria for exempt hospitals, and this generally identified sort of smaller and rural hospitals in the state as exempt. In total, 24 of the state's 62 hospitals are under the payment limit. Next slide. Additionally, as we moved through implementation of this provision with our carriers, OEB and PEB, as part of the Health Authority, established administrative rules to further specify implementation parameters. Within those rules, CMS designated children's hospitals that are not paid under Medicare IPPS are excluded. There's only 3 of those hospitals in the state. We also specified in rule that the actual payments to be made to hospitals by our contracted carriers and TPAs is the lesser of the hospital's bill charges, the insurer or TPA's contracted rates, or the statutory payment limit. I can talk a little bit more about this as we look at our savings recognized as well, but this really was identified based on our work on implementation and the recognition that Medicare rates are not necessarily an ideal benchmark for certain types of care common in younger or commercial populations. In particular, we notice this in sort of maternity and claims for newborns. Payments at or near twice Medicare for these services can result in payment levels that are far above the typical commercial rates. So this criteria around the lesser of the bill charges, contracted rates, or the payment ceiling was really intended to address the fact that in some cases that 200% of Medicare ceiling really is in excess of what a commercial rate would generally be. Next slide. Additionally, a little bit more in terms of what we worked through on implementation and how this unfolded. So just to clarify, so again, I noted, our carriers and TPAs negotiate the contracts with providers on our behalf. So OEB and PEB don't participate in the direct negotiations with hospitals or other providers. However, no contracted hospitals left the network due to the payment cap implementation. So all of the hospitals that we had in network with a health plan prior to the payment limit taking effect remained in network. I think this next bullet probably goes without saying, but hospitals did express concern about the potential impact on their revenue. This was certainly part of the conversation as this was moving through the legislature and as we were working on development of our administrative rules. We did see some indicators that, hospitals in some cases sought increases up to the limit on services that were previously paid below that level. And I think I noted, we certainly saw that on maternity and newborn and had to take some action through administrative rules to address that. And I can note we have not identified any evidence of inappropriate increases in services, delivered or service utilization. Next slide. In terms of savings, so to note, this has been in effect for a little while now. It had an effective date of October of 2019 for the Educators Benefit Board. They have a 10-1 plan year start. And then took effect January of 2020 for the Public Employees Benefit Board in line with the January 1 plan year start. And the cap covers about close to 70% of hospital utilization occurs in capped facilities. So there is still a segment of our utilization, close to a third that is happening in hospitals that are not under this cap, but certainly the majority is in capped facilities. And during the first 2 years, we identified estimated savings at over 160 million. Specifically looking at that first year, 2020, savings came in at about 59 million, which out of that 1.25 billion in our total costs is about 4.5%. You can see on the inpatient side, we actually did not recognize savings in the first year. And that had to do with what we observed in terms of that lesser of requirement not yet being in rule and some increases in claims on maternity and newborns mainly. On the outpatient side, though, we did identify savings in that first year. And then in the second year, 2021, and I should note this is after we clarified and established in our rules that payment was at the lesser of contracted rates, bill charges, or the ceiling. 2021 savings increased significantly to over 100 million, closer to 7% of our 1.6 billion total in medical and pharmacy costs in that year. And you can see there on the side the split between inpatient and outpatient on those savings estimates. Next slide. To note, I think as was observed in the data, the savings were contracted in our outpatient. Outpatient services were higher relative to Medicare in the prior period. At baseline, the average on the outpatient side was at about 285% of Medicare. On the inpatient side, it was more like 235-ish% of Medicare at baseline on average, with some hospitals below 200% on the inpatient side already. Our first year savings were lower than the initial projection. The initial projection was around 81 million, and I mentioned on the previous slide we had savings of 59 million. Couple of reasons for that. I mean, I think one that was previously noted was the unintended higher payments that we addressed through rule updates. And then also being that this took effect in early 2020, there was a kind of a big disruption in service delivery and some changes in utilization patterns pretty early on in 2020 due to COVID. Next slide. In terms of impact, high level, so our carriers and TPAs that have contracted with OEB and PEB have maintained our networks alongside the capped payment levels. We have not experienced concerns or disruption by employees covered under the plans. I do believe that most of our employees don't really know that this is in place. Kind of stands to reason that for the average benefit plan member, they don't really know the specifics of what the contract says between, the insurer and the provider in terms of payment rates. So this has been, I think, pretty behind the scenes for our members. When we looked at, and the most recent I have here today is based on 2022 payments for OEB and PEB, but inpatient payments at capped hospitals were averaging about 165% of Medicare, and the outpatient payments at the capped hospitals were averaging in the 190s, around 190% of Medicare in that range. And I will say our analyses to date, we've looked, done some data review and done some different looks at data as we're able to, and have not really at this point identified or found evidence of disproportionate impacts to other commercial plans. I know that is often a question that comes up when you're talking about a payment provision that applies to a segment of the market. The degree to which there might be impacts on other groups in the market, and we just have not seen evidence of that. Next slide. Further in terms of impact, I mean, again, the goal overall of this is progress towards a sustainable rate of annual cost growth. And I think, it's worth noting that with rates benchmarked to Medicare, I mean, CMS annual updates for IPPS rates generally are near or below that 3.4% level, which is where our benefit programs are capped in terms of annual cost growth. So having the predictability that at least for those hospitals, costs are going to be limited, to increases that kind of trend with Medicare helps on the sustainability side. And then also, that 3.4% limit on PEB and OEB annual benefit growth, it aligns with Oregon's statewide target for sustainable healthcare cost growth. Next slide. And then just a little bit more of a look kind of more recent years in terms of PEB's year-over-year cost growth compared to large employers. And again, the blue line on this graph really shows, trends based on Mercer's data, which we contract with Mercer for our actuarial and consulting services for our benefit programs. So obtain data from them on some of these kind of industry trends. And this is just really showing, and you can see kind of 2020 to 2021, where PEB's annual cost growth has experienced a decrease and has leveled out some, but has really to date stayed at or below the 3.4% mandate. I will note, however, maintaining sustainable cost growth is still an ongoing challenge. And I want to point out that 3.4% for 2025 is projected. I mean, we are in the process of working on, looking at benefit costs for next year, and and anticipate that we will have to continue to work to manage the challenge of year-over-year cost growth. But this policy has certainly helped us recognize a little more, recognize some savings as well as some stability in those annual cost growth trends. Next slide. So just a few final slides on considerations. Again, as I've noted, payment limits are one approach to support sustainable cost growth, but continued strategies are needed. This has really helped us as one tool, but we continue to work on sustainable annual cost growth for our programs so that we can continue to provide comprehensive benefits to our employee groups. Also to note, Medicare is a useful, reasonably transparent benchmark. I think, another positive is that it's broadly familiar. Providers and payers are very familiar with Medicare. So in that respect, I think it's a very good price benchmark. However, I think it does make sense to kind of thoughtfully consider nuances when you're applying Medicare rates to commercial plans. As noted, it may not always be the most accurate price benchmark for services infrequently used by the Medicare population. I think it's also important to consider how any potential retroactive rate adjustments that CMS may provide could impact commercial plan administration. For example, there are times where Medicare may grant a rate adjustment to a hospital and grant that adjustment retroactively. And, to the degree that you have an arrangement in place in a commercial plan that's tied to what Medicare would have paid, there's the potential that you may also have to then retroactively address, or honor any retroactive increases in the payment. So, I do think, one consideration is just to note that it's payments are based on date of service delivered rather than just what Medicare would have paid. It's not something we've encountered frequently, but it has happened that Medicare has granted a retroactive increase, and we've had to go back and potentially reprocess claims, and in a commercial plan that can potentially, result in cost sharing impact to member, changes in cost sharing and things of that nature. We have processes in place to work through that, but I do recommend, taking that into consideration. Next slide. Lastly, I'll note, and this kind of goes without saying, I think, payment ceilings certainly impact contract negotiations. Specifics of that really vary by community. It can potentially result in some providers that might seek payments beyond their current payment levels. It can potentially influence providers' perspectives on, value-based payment approaches or transition away from fee-for-service. And I think that, there's the potential that could go either way. It could provide some greater interest in looking at non-fee-for-service or value-based approaches. It could also potentially, depending on the dynamics, could reduce interest in making the transition away from fee-for-service. And then also just to note, I think there's aspects to this policy that are very much subject to kind of local considerations and local dynamics. Things like where you set the payment ceiling level exactly, what groups or benefit programs are included under a ceiling, what providers, if any, are exempt, who's exempt and who's included. All of those sorts of things are features that can be really informed by data analyses and local considerations. So thank you all for your attention today. That's kind of all I have formally prepared. I'm happy to pause now and hand it back to staff in terms of facilitating any questions folks may have.
Gary, I think you're going to help us with this part.
Sure. Thank you very much, Margaret. Very helpful and informative. And we did leave some time between now and our planned break if folks have questions. So I guess we can just open up to the commission members if you have any questions. Gary, not a commission member.
Commission member. Well, I'll start us off, Margaret. Thank you so much. That was really very informative and helpful. I have a question about labor costs. So hospitals will often rightly say that labor is one huge element of their cost of operation. And particularly at a time as we've had recently where wages are growing at a higher level than they have in the past, that labor costs are going to be a cost growth, that element that the hospitals feel to some degree is outside of their control, right? I mean, and so that leads to a concern that one way of managing reduction in revenue is to reduce a headcount, either through layoffs or attrition or however, and that can then lead to reduction in availability of services and access to care. So I'm wondering how, if you have sort of tried to monitor that or look at that to see whether that's happening, and if so, how you've gone about doing that in order to measure both, on the one hand, employment in the health sector, which is important, for workers, and then secondly, access to care, and whether there's been any reduction in access as a result of the price caps being in place.
Yeah, that's a great question. And yeah, certainly, I mean, you're absolutely right that I think those labor costs have, frequently been identified as something that I think healthcare generally, not just hospitals, is juggling. A couple thoughts there. So in answer to your specific question around whether we have done any specific analysis on that. So no, for OEB and PEB, in terms of our benefits program, we have not looked specifically like at the healthcare workforce or, how this particular policy may interplay with that. I will say, Medicare does in their rate calculations incorporate like certain adjustments for labor costs, geographic wage adjustments. So to the degree that those are already part of the Medicare rate development process, those are captured in our ceiling. So we don't make any sort of separate adjustment or allowance for that. When it comes to access, I think there have been, and especially I think it's the past few years with pent-up demand that from deferred services during the pandemic, and then kind of the restart and re-engagement of folks in the healthcare system. We've certainly heard things related to like, taking longer to get appointments, service backlogs. And I think we've experienced that, just like I think a lot of jurisdictions in the country have experienced, but we have not in any way identified situations where hospital staffing has changed because of this policy, and that has impacted access or the ability of folks to get care or to get quality care. We just haven't seen, haven't identified data that's really pointed to that.
Thank you. And I know there was a health affairs article that looked at your program, and the conclusion, at least of that study, was that there had not been an impact on access to care. One other quick question: does the cap apply to hospital-owned facilities that are off campus, as well as the hospitals themselves?
Well, so it is based. So it applies to the hospitals themselves. Now, like hospital outpatient departments, to the degree that they are under the same provider number, then yeah, I mean, it's based on anything that's under that hospital's, and provider number. I feel like I'm blanking on the specific terms in terms of the hospital provider number, but if it's an outpatient department that is billing as part of that hospital, then yeah, it's all part of the outpatient services.
Thank you.
Thank you, Gary. And Badisha, did you have a question?
Yes. So my question was related to something you said that some of the hospitals sought to increase up to 200% if for some services that were well below that cap. Do you recall what type of services those were?
Yeah, I mean, we really saw that most significantly in like maternity and newborns, where like for those types of services, like the commercial rate, the typical commercial contracted rate is a lot less than double Medicare for the DRGs, and providers were billing and wanting to be paid at that 200% ceiling rate. That caused us to kind of go back and take a look at refining the policy and putting language in rule that incorporated that lesser of requirement. And we have generally seen that, like in cases where commercial, like carriers or insurers are contracting for commercial rates that are less than 200% of Medicare, we are paying the lesser of. So we're paying, the lower contracted rate rather than a 200% ceiling.
Okay, so I mean, it was just those maternity and pediatric services. Those were the only ones.
Yes.
So, okay, so I mean,
overwhelming. I mean, not to say that there weren't perhaps other cases where, there may have been a service where, they could bill up to 200% of Medicare, so they were, and there was potentially a commercial contract, a contracted commercial rate that was lower. But the language we put in rule in terms of lesser of across all services, lesser of, contracted rate, bill charges, or the ceiling, that kind of covered across the board in terms of if there was a contracted rate that was lower than the 200% of Medicare ceiling, then we paid at that lesser of.
Okay, and the other question I had is the savings that were realized for hospital services. Do you know if they differed between for-profit and not-for-profit hospitals, or you didn't?
We haven't really dug into that. I mean, we have looked by hospital, but have not split like nonprofit versus for-profit. So I can't tell you if there was a specific difference between those two categories.
Okay. Yeah. Okay, thank you.
Thank you. Dave.
Hey, Margaret. It's always fun to learn about a sister PEB SEB scenario, or we call it SEB, not OEB. I think I'm missing something, and I just need help reconciling a number in my head. I was looking at slide 6 that has the box and whisker plots and shows the range of payments that were happening that were in the 185 to 340 and the 215 to 375 range. And then I was trying to reconcile that with the impact that's described on slide 13 that says capped hospitals are at roughly 165 and for inpatient and 190 for outpatient. And I was trying to figure out how are they below that cap? How is their average that, which is below your 200% cap, but also lower than the range that was on the box and whisker plots? So can you help me? Well, I'm missing something.
Yeah, for sure. So this data on slide 13 is based on 2022. So this is after the cap has been in place for a couple of years. These percentages, about 165 on the inpatient and in the 190s on the outpatient. That's what we were recognizing. The previous data on slide 6 was before cap implementation. That's 2017 data. So that was, and this is specifically data on large PEB and OEB payments to large hospitals in Oregon back in 2017. So when there was not yet a cap in place, and just prior to implementation of the cap, this was kind of the range that was observed. There were some that were on the lower end, closer to 200, or even on the inpatient side below 200. But it just, a broad range without a lot of rhyme or reason as to why the range existed.
So this slide is was only the large hospital systems, but the slide 13 impacts was all parts, all providers that were impacted by the legislation, a broader denominator?
Yeah, well, no, they're the same group, but this one is 2017 before they were capped, and then slide 13 is 2022 after they were capped.
So I guess the part I'm missing is, let's
Mhm.
just take inpatient here. The
Yeah.
low end of the range is 185,
Mm-hmm.
but yet the average after implementation is even lower than the low end. So even though the cap was higher than the low end back in 2017, you had further reductions.
Yeah, I mean, that's what our actuaries are showing most recently in terms of that lesser and I think there's been some of the kind of academic health affairs research that has looked at PEB and OEB payments compared to other commercial payers and I mean, I think we infer potentially that we have gotten a little bit closer to maybe some better rates on the commercial side, I guess, for lack of a better way to put it. And our actuaries continue to review those percentages of Medicare. So the numbers on slide 13 are from 2022. We're looking pretty closely at 2023 and soon to be 2024 now. To kind of, and I think what we'd like to do is get a few years of data and see, are we continuing to stay below 200, or are things gradually starting to really move toward that ceiling? I don't think we know yet. Based on data we've looked at through 22, we are seeing some runway below 200% of Medicare on those. But yeah, I think I will tell you, this is particularly an area. I was talking to our actuaries a little earlier this week, and this is an area where I'm really interested to see some additional years of data in terms of, we were looking in the like 165 range on the inpatient, and are we staying there, or are we noticing movement? So yeah, I hope to be able to, maybe the next time I speak with you, have a little bit more to share on that.
All right, thank you. It's very helpful.
Yeah.
And Joan.
This is not nearly as a precise or as intelligent a question. My thought was more in anticipation of the rural topic we're going to come to in a minute, and having grown up in a more rural area. When we passed our public option bill, which was sort of established reference pricing as well on the individual market side for our public option program in aggregate, and we're closely looking at the PEB-ZEB bill to see if there's some best practices. We could learn from each other there if it moves forward. But there's always concern about the reference pricing sort of adversely impacting smaller rural hospitals. And I think I missed what you had said about the exclusion you ended up doing. But my question was more, if you have anything you observed, the concern would be that you're leaving rural areas out of the benefits of potentially reference-based pricing. But then the concern, there's two sides of this coin if you're excluding rural, smaller rural hospitals, specialty hospitals. So anyway, just interested in if you all have done some thinking about your exclusions, or if you've observed anything in relative pricing between people subject to the cap and not subject to the cap that would be interesting for us to think about as we're looking at it in Washington.
I mean, it is a really great consideration, and you're right. The distinction between the larger DRG hospitals and rural hospitals. I mean, there's a lot to consider there. We know, as I said, about 30-ish%, around a third of our utilization is happening in hospitals that aren't capped. Some of it is happening in hospitals out of state. But some of it is happening at the in-state rurals that are exempt. I mean, we do know that, like, when we look at percent of Medicare levels for those exempt hospitals, because we do look, they run higher. I mean, certainly they're in excess of the 200% cap. that the 200% cap that does not apply to them, that applies to the larger hospitals. So, I do think it's, there's a lot of considerations there. And we in Oregon, at least, for OAB and PEB to date, we have not looked at any sort of specific changes to how we approach payment for the exempt rural hospitals. We just haven't. But it is a challenge. It's that balance, I think, between wanting to ensure sustainable cost and pursue, cost containment in hopefully a data informed and kind of strategic way, while also wanting to ensure access in rural areas and support those providers in staying in business. So yeah, I mean it's a great question, and we just to date, I mean, we look at data and have done some just, number crunching on those exempt hospitals just to kind of see where things are at, but have not really looked at, specific changes to payment policy for those.
Thanks. When you all solve that, come back. We'll be here.
Fair enough. Yeah.
Appreciate it.
Yeah, absolutely. Thanks for the question.
Thank you.
And Margaret, I know you do need to make sure we wrap this up by 4:00. And so we probably have time for one more question if anyone has any more. I don't see hands. So thank you very much for this extremely helpful and informative presentation. And Vicki, I'm going to turn it back to you.
Thank you.
Thank you, Margaret. And I'm going to send us off to a 10-minute break. So we'll be back at 4:02.
Thanks, everyone.
Great, thank you. We're having a really interesting conversation in the room. Sorry for the delay. Welcome back, everybody. And I'm gonna hand it over to Liz from HMA, who's gonna kick off our rural health roundtable. Liz?
Thanks, Vicki. Can you all hear me? I'm on my headphones and sometimes they're weird.
I can hear you.
Okay, great. And I just want to ask Gary quickly if there was anything that we wanted to reflect back from the conversation with the Oregon folks before we move specifically more into the rural conversation.
Well, I mean, I think the commission voted this morning, or this afternoon, so I think we can move on. Thank you.
Great. Okay, thanks, Gary. So we have, following our conversation in December, where we first talked about the bill that the commission voted on earlier, there was a specific request about what would the impact be on rural communities. And I just should mention that over the last 3 years plus that I've had the opportunity to support the work of the commission, rural health issues have come up quite frequently, lots of questions about, well, what does this mean? And so following that conversation in December, HCA staff worked really hard to find a panel of folks representing rural communities to speak specifically to some of the unique challenges that rural health care providers experience, so that the commission could really have those sort of perspectives in mind as we continue the work to design the universal system. And so I'm pleased today that we have a few folks with us. We have Brad Becker representing the Rural Health Collaborative, and Shane McGuire from Columbia County Health System, and then Ashlyn Strong from the Washington State Hospital Association. And when I turn it over to them, I'm going to ask them to please, actually, I'm going to turn it over to them real quickly to just do a quick intro. And then I'll outline our plan for today, and we'll get going with our conversation. So, Brad?
Thank you. And again, I just want to thank the commission for this opportunity to come and have this roundtable discussion. Brad Becker, again, I'm with the Rural Collaborative. We are a group of 27 rural tax-supported public hospital districts across Washington State. And we're working collaboratively together to help to assure the survivability of our members. And frankly, a couple of our strategic plans that we're focusing on are to address the cost pressures being put on hospitals. Real quickly, my career goes back many decades, actually started on the payer side. So I have experience in understanding the dynamics and pressures of the payers. The last 20 plus years, I've been in various hospitals, a larger health system. I've also spent over 20 years focusing on revenue cycle. So I'm very aware of the challenges and how revenue cycle has changed over the last 20 plus years. Thank you.
Thanks, Brad. Shane?
Hi, I want to thank the commission as well. You guys are taking on some really challenging thoughts. Really appreciate the energy you're pouring into this, and the fact that you're looking at different solutions to some of the vexing problems that we see here in rural and have seen in the transition to more of a value-based option. My name is Shane McGuire. I'm located here in Dayton, Washington, Columbia County, southeastern Washington, just outside of Walla Walla. We're a public hospital district. We actually span 2 counties. We're in a portion of Walla Walla and Columbia County. Pretty small population, one of the smaller counties in the state of Washington, about 4.2 people per square mile. We do have a distinction, though, of being a place where people recreate. About 45 to 50,000 skiers a year to Bluewood. Lots of outdoors folks. Palouse Falls is fairly close to us. They have 90 to 100,000 visitors a year. So in addition to being sort of rural, we are a place where people come and recreate. Those people often use healthcare. We are where 25% of the wind energy in Washington State comes from. Southeastern Washington has the distinction of producing a great portion of the wheat and the grains that Washington State creates. Washington State ranks 6th in the nation for wheat growth. A lot of that comes from this area. So thank you for including our voice. We feel like we represent the rural community, the farmers, and the folks that live out here working hard for Washington.
Thanks, Shane. And finally, Ashlyn.
Hi, Liz.
Hi, good to see you.
Yeah, we used to work together. So I'm Ashlyn Strong, the Vice President of Government Affairs for the Washington State Hospital Association. We represent Washington's 100 community hospitals, more than 90% of which are public or nonprofit organizations. I am not from a rural community. I'm a poor replacement, unfortunately, for our CFO, Eric Lewis, who used to run a rural hospital, actually the one I was born in. And he had another commitment today. But we do represent all of the state's rural hospitals, so I'm happy to be here today.
Thanks so much, Ashlyn. So can we go to the next slide? So welcome to our panelists. And just to sort of remind everyone again, we're really here to talk specifically about the opportunities and challenges facing these communities and really think about them as they come up against the topics that that the Commission is currently talking about around cost containment. And I think it's great that we heard from our friends down south in Oregon earlier, and you heard specifically some of the pieces of their work that they've been doing with their reference-based pricing and how they've had to make some special considerations and really think about the impact in rural communities of those policy interventions. So really that is what the goal of today's conversation is to hear more specifically about those issues and hear from our panelists about what some ideas are, or what would the future look like for them if they had a magic wand. So really excited to be able to have that conversation. And we have a few questions that we've worked on with the staff to facilitate today's conversation. And then we'll have an opportunity for commissioners to specifically ask questions later. And at the end, we'll do a quick summary of what staff and myself have heard so that we can reflect that back to the FTAC, and they can think about that as they continue their design work in the cost containment arena. So real quickly, we have a couple of slides just to make sure everybody's level set about what we talk about when we meet, what we mean when we say rural health community or rural communities. So let's go to the next slide. It's just one quick slide. So in our state, approximately 21% of the population lives in what is considered a rural community. And in terms of healthcare services, that means there are 39 critical access hospitals, 6 rural hospitals, 34 tribal clinics, 123 rural health clinics, 44 free clinics, and 218 rural federally qualified health center sites. So this is information that has been gathered by staff from the Office of Financial Management, and just to really show a picture of what this looks like. And we can leave that up for a second, and I just want to ask our panelists, looking at this map, how does this mesh with your experience as providers?
Well, I'll jump in initially, and I think when I look at the map, I think there's another important component to that, and that is if we look at the critical access hospitals and then the 6 others who aren't, of the 39 critical access hospitals, 32 of those and 5 of the other 6 are not only rural, but they're tax-supported public hospital districts, like Shane. And so in thinking about the conversation, I know there's been lots of discussions and perceptions about some large health systems, for-profit hospitals. I think what we want to also help remind the group today is not only are these rurals, but the vast majority of these have additional taxpayer funding. And so when we talk about funding, when there's deficits, it's the taxpayers who help make that up. And so I think that's an important component. And we look at the geography too, in terms of the just geographical expanse of Washington that's rural. Shane, if you have other comments to add from your perspective, thank you.
Yeah, the one thing I would say is it gets really easy to focus on those lines, right, that define counties, and then there may be a hospital within those lines. And so contextually, we try to say, what's the budget for this hospital within these lines? And I think the reality of the situation is there's a huge interdependence that maybe not realized here, where hospitals that are in more urban centers, they're still designated rural, right? They're still in the green parts of the map, are oftentimes sharing patients across those county lines. And that might be specialty care received in Walla Walla for residents who live in Columbia County, or residents in Benton, Franklin, or even Spokane County that need post-acute care that are actually rehabbing in Columbia County. And so I want to be careful to say that rural isn't just defined by these county lines and populations per square mile. Sometimes you get these quadrants of the state that are all relying on one another and interdependent upon each other, especially given sort of the limited bed capacity that we have. So that would be the one thing that I'd want to point out, especially when we look in things in terms of counties or maps.
Thank you both so much. Ashlyn, anything to add?
Yeah, just building on that, I would say a lot of folks don't know that Washington State ranks 50th among states in terms of hospital beds per capita. So we really rely on access to care in all of these rural communities. And a lot of the hospitals, including the ones that Shane and Brad work for, are really anchors in their communities. A lot of them are the largest employer in the community, for example. It's really a place that holds the community together. And so their financial sustainability is really important. So I'm glad we're having this conversation today.
Great. Thank you all for putting some context around the numbers and the maps. I think it really helps to kind of convey what we're talking about, and it's not just simple like boxes and puzzle. It's very complicated, and there's a lot of interdependencies. So appreciate that. So our first question is, what are the most significant factors that are contributing to the higher costs that are experienced in rural healthcare settings? We talked a little bit about that earlier. We heard a little bit about that from our friend down south, but we'd just love to hear from you all specifically. From your experience, what are the most significant factors?
Yeah, you can probably kick us off here. I think context matters. Rural hospitals in Washington State make up about 10% of the total hospital spend. And so we want to just kind of keep that in mind as we talk about it. Things are expensive in rural, but in the context of a larger healthcare network or system of healthcare providers, it is a smaller number. Salaries and benefits, 60%, agency labor, 10%, professional fees, 13%. 83% of my budget is labor or labor related. And so, oftentimes these things are really tough when you start talking about cost containment and maybe sometimes a ill perception that operating in rural should be less expensive or the cost of labor should be less expensive. 50% of my labor pool drives in from other communities. I have large hospital systems that are 35 miles away, and if I attempt to pay nurses less than they could make at another hospital, they're not going to work at our facility. This goes towards our technologists, our lab techs, our radiology techs. I would also say that a lot of us are operating in older facilities. My facility was built in 1964 and 1969. It's not the most efficient building to operate in. It's incredibly expensive to work on. And I have to say that electronic health record systems are incredibly expensive. We just got through a massive EHR upgrade. You're talking about hundreds of thousands of dollars, tens of thousands of dollars a month to support that system. Really outside of labor building and some of the incredible expenses associated with delivering healthcare, it becomes awful difficult to say, where do you cut, without also saying, which services do I cut?
Brad, anything to add? Go ahead.
Ashlyn, did you want to go next or?
Sure. I just wanted to talk a little bit about the reason that we see significantly higher costs kind of per case in a rural environment, and that has to do with having low volumes of patients. So if you think about a hospital with an emergency department or a labor and delivery unit, even a small one has to be open 24 hours a day, 365 days a year. And we have a lot of, I think labor and delivery is a really good example because there's several hospitals with labor and delivery units that only have 50 or fewer births per year. So that's like once a week, but you still have to staff to be open 24/7 because you don't know when that baby is going to, or, you know, the pregnant person is going to walk in the door and ready to deliver. And you have to have, you know, not just midwives, but also surgeons in case you need an emergency surgery, for example. So these are things that cost a lot, and you can't make up for that, the payment of those fixed costs through a per case payment, like a Medicare payment's never going to capture the full cost of keeping those services open and available 24/7. Brad?
Yeah, just to kind of what Shane talked about with labor, my home organization, Mason Health in Mason County, where we're located, we actually have a large number of employees that we actually draw from the neighboring 5 counties. And as such, as Shane alluded to in the market, we have to be competitive with the nursing salaries and every other salary. We also find for entry-level positions, we were very much struggling in our dietary areas and housekeeping, because as we interviewed everyone, they were declining positions, saying I can make more at Starbucks, I can make more at McDonald's. So we're competing with the entry-level positions for those salaries. The other comment, I think again in the supplies, obviously we're seeing the escalation in pharmacy costs, and what Ashlyn alluded to in variable volumes. Even if you're a fairly large facility, and I'll use Mason, who does hundreds and hundreds of deliveries a year, we have days with no one in the OB unit. We have days with 4 or 5 in the unit. We have a relatively busy emergency department, but again, we'll have a day with 25 patients. On the weekend, we'll have 60. Our inpatient census can go from 12, and currently now during the flu pandemic and RSVP, we've hit our 25 max a number of times. So the swings can be 2-3 times, and that's what creates one of the huge cost pressures.
Yeah, I think I'd like to add a couple of things. When we are looking for agency labor, which is given the nurse shortage nationally, but also in the state, oftentimes nurses will ask for additional money per hour to come to a rural environment that they may not in an urban environment. And so it's not unusual for me to have to pay up to $115 an hour for agency labor. That rate may be closer to $85 an hour in an urban center. And so when it comes to agency labor, when we're looking at how we staff our floors, one nurse could be 20% of the nurse staffing on our shift. And so if you have a nurse call out, or you have a nurse on vacation, or a nurse on FMLA or PFMLA, replacing that position at $115 an hour is a requirement. We would be understaffed otherwise. And so those are other things that are pushing costs up higher. And I want to say one more thing about rural, because we're the largest facilities, anchor tenants, we are looked at to provide additional services that maybe urban centers don't. I did 1,100 non-emergent and medical transports last year for about 80,000 miles. I have 4 vehicles that their entire job is to just transport people to non-emergent appointments so that they can get access to care. There's no direct reimbursement for that. It's absolutely a requirement in this community, but there's no way to get funding for it. And so it adds to operational expenses.
Thank you. That's really helpful. And that kind of leads into our next question. If you want to go to the next slide, Mary. Oh, sorry, go back one. I don't know what happened. Wait, something happened with these. There was another slide that I had, but in any event, I think let's not worry about that. But what are some other challenges that you all face in terms of providing healthcare in rural communities? You just mentioned like transportation and the things that you do that are not necessarily considered healthcare services. So just would like to hear a little bit more about some of the things that you are experiencing in terms of being able to provide care and what your community needs. Yeah, go ahead.
Yeah, I think one of the hardest things is that, I know this is a sort of med advantage conversation for me, but it's not different really from a state perspective. It's hard for us to contract with payers. I mean, we're small, we're price takers, not price setters. And so when you have a payer who brings you an agreement that is under your cost of operation, and then you explain that and they say, well, you don't have to sign it, it creates an issue with access to care, right? Because they're advertising in the community. They're pushing people onto their plans. But then when the care is delivered, it's not always compensated because we're considered out of network. And so I think that's a fairly unique problem for smaller rural systems that maybe doesn't exist for larger centers that can have better negotiating power, if you will.
And, picking up on that, I think this does have a state applicability too, when there's a multitude of plans. And, I won't start to go down the rabbit hole about single payer. I know there's so much discussion and emotion around that. But I think just with the variability of the rules and processes, it adds the administrative cost. And we see where the larger systems, due to their economies of scale, they can purchase artificial intelligence now, or they have very sophisticated systems where they're able to manage the variety of rules. We struggle. I mean, I was just looking at some data recently, and this happened to be on the Medicaid side. And I looked at Shanes County of Columbia, where 4 of the 5 managed Medicaid plans are in his county, and Columbia County, across all the managed Medicaid products, has 971 enrollees. So under 1,000 people. So Shane's operation for less than 1,000 people has to manage 4 set of often very different rules and processes. And anytime in any system, when you have variety and differences, the cost goes up.
Yeah, and I think the other thing we should acknowledge is we're older. Columbia County is set to be the 4th oldest county in the state of Washington by 2030.
Yeah.
29.7% of my population is over the age of 65, 4.1% is over the age of 85, and the median age is 50 years old. So by comparison, Washington State, 17.1% over 65 with a median age of 37.7. There's a stat out there somewhere that says anybody over the age of 65 will have at least one chronic disease that they're managing. And so it's a much sicker population. And I think that the other challenge is a little bit about perception. You look at a daily rate for a hospital bed at a critical access hospital, and you say that's 5 or 6 times what it can be at a skilled nursing facility somewhere else. We don't often stop to look at total cost of care. When I look at my Medicare beneficiaries, that older, sicker population, 2023 was the worst year I've had, but I hit the national benchmark for cost per beneficiary and spend. So even while my cost of services is expensive, when you look at it from a charge master or a daily perspective, when you look at the total cost of care, you realize that we're managing total cost by managing the entirety of the patient, trying to keep them out of those expensive beds, trying to keep them out of the ER. That's where transportation comes in, right? If we get them to their appointment, we can keep them out of states of disease, right? And so, sort of a bigger picture look rather than that sort of like micro look at your daily rates are too high. What is the total cost per beneficiary in a rural environment versus an urban environment? And it's not nearly as bad as some people think.
Mm-hmm. Well, and what I think I'm hearing you all say too is that being able to having the support to be able to move people to different settings and have that interconnectedness to manage the overall individual's experience rather than just the day in the hospital makes a difference. So needing support for more of those kinds of things.
Yes, social unmet social needs, right? That's some of what we're talking about.
Exactly. I'm going to pause for a second and see if any of our commissioners want to follow up and ask any specific questions to you all on what we've already talked about before we move on to our next question. So just going to pause for a second. I don't know, Vicky or Joan, Jane, Badisha, Dave, any questions you all have that have been sort of triggered by the conversation that we've had so far?
This is Vicky. I do have a question. I'm wondering about, and I think there was a comment that's kind of verging on this. What are the impacts of the behavioral health crisis system not having enough beds for people on your hospitals? Do you do a lot of single bed certifications?
Brad, do you mind?
Go ahead, Shane.
Okay. We don't single bed certify, first of all. We do integrated models of care. So our rural health clinics have behavioral health specialists working alongside our primary care providers. So a lot of what we do is to try to keep people out of those crisis states. Crisis management comes out of a different county for us. And so a lot of times we're left to try to work with the patient and work through the issue while we're waiting for a crisis response. I have a philosophy. I haven't gotten us totally to where I want us to be, but this concept that a rural mental health patient or a patient in crisis in rural needs to go somewhere else for their care doesn't sit well for me. It's like exporting my problem and making it somebody else's, right? And so the more services that I can start applying for SUD or mental health, and the more maintenance I can do with those patients, the less exacerbations of disease that can happen. And so that's part of our goal for our facility. We definitely have had situations where we've had to board patients in the ER for multiple days. It's very taxing on an organization when you have 3 nurses on the floor and you have to have a 1-to-1. And so those aren't great experiences, but they're experiences we acknowledge are sort of part of the mission. And we're trying to limit the amount of times that happens.
I think Shane provided a very good summary. I think at this point, I have nothing else to add. Thanks, Shane.
Ashlyn, anything from the WISHA perspective on behavioral health in rural communities?
Nothing to add.
Okay, that's a great question, Vicki. Any other commissioners have specific questions they want to ask our panelists before we move on? Okay. All right, why don't we go to our next question? So imagine, it's 2 questions. So imagine, this is the fun part, imagine the current health system is gone and there's a new system in place. What do you need to make a new system sustainable from your perspective?
Well, I can start with that one, and I think I alluded to it earlier. This new system, I would love one, and again, it doesn't have to be single payer, but consistent rules and processes. Because again, we spend hundreds of hours and staff trying to ferret through continuous updates and different rules and processes. And then even when we get into population health, the data that I shared earlier around the managed Medicaid organizations, even in a larger county like Mason, when you have the population spread out and then you have different population health or value-based care initiatives, they're competing with each other and you can't provide standardized care. But having consistent processes and regulations that we don't have to continue to hire either employees to administer all of the rules or invest in AI, that starts to lower our cost. And then as we look at the whole system, then it becomes less expensive. I would start there. Shane or Ashlyn, I'll let you add to that.
Man, these magic wand questions, I love them. So actual cost of care versus total cost of care or real cost of care are two things that we need to just get on the table. When people say that we're cost-based reimbursed, we're actually reimbursed on approved costs. So it's not actually total cost of care, which ensures basically an operational loss. You know, I had a 9% operational loss last year, and the year before it was a disastrous 20%. If we don't find a way to stop the bleeding, it's going to be very, very difficult to sustain operations. And so I caution that even when we're looking at global budgets, the data that you use for what it costs to operate a service line like the emergency department doesn't actually include all of the costs. It only includes the portion of the costs that are allowable. Okay. We would argue that those other costs are just as necessary because they, frankly, the service couldn't function without them. But they tend to focus on things like, you know, provider's time face-to-face is a carve-out. It only covers the time for the provider when he's not seeing the patient, right? So standby time. It's a really important component in rule. You know, a solution for rule, in my opinion, has to include something for long-term care. We've closed down so many nursing homes in rural environments. I started an ALF. I closed my nursing home down in 23. We moved everybody into an ALF. It is 63% Medicaid. If I had to relocate those Medicaid beneficiaries, they would have to scatter all across the state of Washington to find Medicaid beds because they're just not available. You know, we have an initiative here called Aging in Place. And so, you know, a solution would include some form of reimbursement to help people age in place, and whether that's in their home or in an ALF, but to maintain their residency in the community without having to move them somewhere else because there aren't services here. It would include inpatient services. I think there's this desire to say, well, there's so much overhead associated with it. The overhead goes away when you close inpatient programs. It's not necessarily true. The way we staff our nurses is they flex back and forth between the emergency department and the floor. I would lose that ability if I didn't have inpatients. I would have to staff at a higher level of nurses to ensure that I can handle any kind of crisis that would come in. Whereas right now I staff one nurse dedicated to the ER and I'll float nurses back off the floor if I have to. Those fixed costs allow us to make efficient use of them. It also allows us to generate revenue and add to the solution to the beds in the state of Washington, which you heard earlier, we're at the lowest per capita really in the nation at this point. I think services need to be available in reasonable timeframes. I have an example that comes to mind with regards to home health. Home health services is often something that we look at that actually decreases total cost of care. The home health certificate of need for Columbia County is held by a different community and a different provider. When I look at the utilization per beneficiary for home health services, it is half of what it is in the neighboring county, even though the neighboring county is the one who provides home health services. Distance doesn't always lend itself well to access to care. That is an OMF number, by the way. Office of Financial Management is where that information came from. I think we should still be able to innovate. There was no advanced wound care treatment option in our region. Walla Walla did not have an advanced wound care service line. And so Columbia County actually started one. And I would say 80% of our patients travel from out of the area to Columbia County for advanced wound care treatment. In absence of that, we'd have increased amputations, and the 5-year survival rate after a lower limb amputation is about 50%. Your cost of care goes through the roof if you have an amputation as well. And so there are times when I think rural can innovate and can find a way to provide advanced services that maybe we wouldn't think of them providing, especially when there's a need.
Definitely sounds like you are doing a lot of innovation, and having an environment that supports more of that to be flexible is a key important piece. And I also heard you say, Brad, the need for administrative simplification for providers, and the commission has talked about that quite a bit. But I think you helped make it real. We already knew it was an issue, but it's even more acute in rural hospitals or for rural providers where there's smaller numbers of people, and still you have, like you said, 5 Medicaid managed care plans, all expecting something different, and the populations are so much smaller. So that's really helpful information. Any follow-up questions from our commissioners on this question before we move to the next one?
Liz, I think Mohammed's hand may have been up earlier.
Oh,
Mohammed, I don't
okay,
know if you
great. Mohammed?
if you had put it up. See here?
I did. Thank you very much, Liz and team for preparing the questions. These are really good questions, and the information is there's a lot of intersectionality, especially in county. Populations like the immigrant refugees, older population. We have older folks, and utilizing care is not as literacy level is low, so people usually don't do a lot of private care, and that's what we try to encourage. The one quick question that I have is, do you guys also deal with uninsured population? And then also, I know we have there's a lot of issues within the community and in other communities about the cost of transport, especially if somebody needs an ambulance to go to a hospital. Even though they might have insurance, there's a lot of out of pocket for that. So those two maybe. Thank you.
Brad or Shane?
Want to
Which one do you
start,
want to
Shane,
take
on
that?
the uncompensated in your county? And
Sure. I mean, we can say uninsured, but we can also say underinsured, right? Because they may have insurance, but they may have deductibles that are so high that it's almost about the equivalent of not being insured in some cases. We're currently carrying almost close to $2 million in self-pay balances. We're not a bank, but we are actually carrying those expenses right now. And there's no great way to collect, especially in a small community like this. These are your friends and your neighbors, these are your family members. Every year we get a report, or every month we get a report in front of us as a bad debt report. And we don't necessarily know the names because we stripped that from there. But one thing we have done is we've highlighted that report in yellow for anybody or any account that has gone unpaid before, meaning that person has received services that they haven't paid before. 3/4 of that list is yellow, meaning 3/4 of the people that are on that list every month are the same people that were on it the previous month for different accounts and different services used. Our emergency department, we honor EMTALA, right? Anybody can be seen regardless of your ability to pay. And so it's one of the areas where we have the highest costs of care. And I think in a rural environment where there's not an urgent care center and the closest urgent cares are usually 40 minutes away and a car ride, transportation's tough. They will often use the ER as an urgent care option. Transportation, we are trying to limit use of emergency transportation by providing non-emergent transportation. We also partner with Columbia County Transportation locally for that. And I think the other thing to consider is there's not really private ambulance services in many rural communities. It's usually our fire departments, which are also municipalities and taxing authorities. And so I think it's really important here to understand that the tax base in these rural environments are not only taxing themselves for the hospital and healthcare, they're taxing themselves for EMS, they're taxing themselves for fire departments. And they have all of the attributions of high cost of care and coverage and insurance. And in addition to that, they're paying to make sure this hospital can stay here and that the ambulance will come when they call.
Just to follow up on one of Shane's points, and I think, he hit it spot on. It's not just uninsured. Again, with the high deductibles, where it disproportionately hits rural facilities is we've seen the statistics that nationally, I think the average deductible, and I apologize, I'm having a midlife moment, but I think it's like 3,000 or 4,000 or something. I look at even a larger rural facility like Mason Health, and when I ran the revenue cycle, we looked at all of our accounts, and over 80%, 85% of our accounts, the charges were under $5,000. They're our clinic, they're the lab only, they're the x-ray, they're the rehab. So when you look at that, a high disproportionate amount of those accounts for people that have the high deductibles, in a sense, become self-pay. Where we're different is, yes, some of the larger facilities have those low counts. We don't have the $1 million babies. We don't have the transplants. We don't have the cardiac surgery. And when you get to the high end of those, that distribution, even if someone has a $5,000 deductible and can't pay it, 95% or more of the payment is still coming from the health plan. We have lots and lots of accounts where it's covered under the health plan, but the health plan pays zero. It's going to deductible, or the health plan pays a small amount. It's going to deductible and co-insurance. So what we're dealing with, someone may figuratively have insurance, but it really actually is self-pay.
Thank you for sharing that. I think what I am hearing from you all is the issue about affordability is hits much closer to, for individuals, hits much closer to home for you all providing these services. At the same time, the costs are for just the cost of doing business are higher, and so you're in a really unique position. Given that, with the focus that you've heard about on cost containment from today, and also other conversations happening in the state, and you've given a couple of thoughts about what needs to be considered important for rural communities. How can cost containment, let's go to the next slide, avoid negative impacts on rural health, access, and quality? Any ideas or thoughts that you might have as this commission moves forward?
Yeah, I want to tell you a quick story, if you don't mind. We had a patient who was a Medicare beneficiary, who was a quadriplegic. We took care of this gentleman for 3 years in chronic care management, palliative care. As someone who's in that kind of a position, they would have moments of exacerbation of disease, so pneumonia and or wounds. That gentleman got switched over to a Med Advantage plan, and if I had to guess, it was probably partially their decision as well, because fixed incomes have to make tough choices themselves. Some of the cost control mechanisms that we see happen with prior authorizations and contracting and network adequacy, they are meant to control costs. But for this gentleman, they ended up having a surgery. They needed a skin flap. When he went to discharge to our facility back to the team that knew him best, we were denied the ability to take that patient in. That patient ended up in a lower cost skilled nursing facility 60 miles away with a care team that knew nothing about his care or his situation. He wasn't put on a sand bed. He wasn't put on any kind of special environment. Our team actually drove the 60 miles to check in on him, and the state he was in caused them to call an ambulance and had him take to emergency immediately because he had broke down so badly and so poorly. By the time we got him home on hospice, and he passed away. We went from 3 years of a life that had quality for him, that he could articulate, to a lower cost solution that had cost savings built into it that ultimately led probably to his death. And so anytime we talk about cost control, I want to be just very, very careful that we don't have these unintended consequences of we saved a daily rate at the cost or expense of a patient. Okay, so I kind of want to start there. I feel absolutely dedicated and committed to this task of lowering costs. Palliative care isn't reimbursed directly. It is something we do because we see it as better care. That patient panel is the sickest panel we usually deal with. They're right before hospice care. Because we do palliative care here, we're able to reduce their ER utilization by 35%. We know this, we tested it, we actually ran a statistical analysis, p-value, the whole bit, right? We know we'd reduced, through that intervention, ED utilization by 35%. We did it using a service line that doesn't have direct reimbursement, and we don't get to share in any of the savings that were generated by the lack of ED utilization. And so I do think that there are interventions that can be done in rural to lower total cost of care. I think we're going to have to find ways to sustain them. And I think we're going to have to at least reward, to a certain extent, a portion of those shared savings back to those programs. They're not going to align with a CPT code. They're not going to align with a billing code or a fee-for-service model. They are usually addressing social determinants of care or lifestyle or things that are in the home. And so, part of that from a rural perspective is making sure that there's funding that is flexible enough to allow that. I would also say, like, a common EHR. The electronic health record systems eat us up in rural. The expenses are extraordinary. They normally don't integrate or interface with the large health systems around us. And so we have a lot of overhead associated with faxing pieces of paper back and forth, or trying to chase down notes from other providers that are using an Epic system when we're on a Meditech system. I think there's a real opportunity there to look at some form of methodology of unified communication and care delivery.
Thank you, Shane. Anything to add, Brad, before we move to our last lightning round question?
So Liz,
No, I would encourage.
Oh, sorry. Jay, I heard one of our commissioners. Go ahead.
So go ahead.
Shane, can I follow up?
Sure.
So I'm with the Office of the Insurance Commissioner, and we are right now facilitating a study on palliative care, and we're working with an actuary to figure out how we can cost out a palliative care payment methodology, and we're looking at both commercial health plans and Medicaid. So I would love it. Liz can get you my contact information. I would love it if you would share with us the data that you just cited about the success of your using the palliative care model in your community.
As long as I can start calling you Saint Jane, I'll be happy to do that, because if you can find a way to make something like that happen, I would be greatly appreciative.
Well, we're going to be putting together a report back to the legislature, so they'll have it for next session. But any information that you can provide about the reduced ED utilization. And the other thing I'll note is the story that you told about the fellow that shifted to Medicare Advantage is tragic. And one of the frustrations that we have is that we get tons of complaints about Medicare Advantage, and we have no authority at the Office of the Insurance Commissioner over Medicare Advantage. And so the new commissioner's big drive is to say, all right, if we can't regulate them, then we need to do a better job of educating consumers about what their choices are. And so we actually just, Representative Tai and Senator Slatter have put in requests for this upcoming budget to do a big funding increase for our SHIBA program so that people understand what Medicare Advantage is.
Yeah. SHIBA's amazing. I appreciate it. And I know that there was some focus on the Med Advantage plan, but we just don't want to repeat the same mistakes, right? And whatever we develop, we don't want to be chasing some of the similar maybe short-sighted savings, right? We want more holistic and long-term solutions. So thank you for that. And we agree with you 100%. Education and user education is critical.
Yeah. Yep, and we're very, very conscious of how much more a Medigap plan costs than the zero premium Medicare Advantage plans. We totally get it. And one of the things that we always worry about is that higher income people can afford MedSup, so they stay outside of Medicare Advantage, and lower income folks who don't qualify for the Medicare savings programs end up choosing Medicare Advantage because they can afford it.
Exactly.
Yep. No, we get it. We get it. Thank you for what you're doing.
And Jane, there's a Medicare-like Advantage plan that the Healthcare Authority has oversight over, right? It's the D-SNP plans, and I know I said I wasn't using acronyms anymore, but I can't remember what D-SNP stands for.
Disabled,
dual special needs plans.
Yeah.
Yeah, the D-SNP plans are for folks who are both Medicare and Medicaid eligible, and it's a Medicare Advantage plus Medicaid all rolled together.
So, but the Healthcare Authority does actually have some authority over those plans.
Yeah, that's a really good question. I do not know.
Go to when we have issues with them, because the tribes have had a lot of issues
with the
tribal
D-SNPs.
members getting stuck on those plans just because they wanted free groceries.
Yeah.
So
I get that.
we have a few minutes left. Brad, I know you wanted to share something earlier, and then I think that Bob Murray also had a comment as well. So Brad, go ahead, and then
no, I was recognizing we have another question, but just kind of a general theme on cost containment. I would say if we can look at the whole system in totality, and one idea is, are there functions and where they're done, if we move them, it maybe bumps the cost somewhere else, but exponentially lowers it in other areas. And I've got ideas as I brainstorm. What if this part of the system did that? Could they be more efficient? So in general, I know we're running out of time today, but I think to look at it from a broader perspective, again, not necessarily avoiding the negative impact, but actually allowing us, again, anything we can do to help control that cost curve that then can translate into the rate side. So thank you.
Definitely appreciate that. And I think Shane's example of just turning things on the head with the palliative care and wondering why aren't we doing more of that for folks. I think that's a great example. So thank you both so much. Bob, last question.
Yeah, I just want to make a comment. I think it's been a very useful presentation, and it sort of highlights the significant differences between small rural hospitals and hospitals that are in more urban areas that have developed pricing power, market power to increase prices and spending. And I just want to make a point. I mean, in the future, I'd be happy to do a presentation on global budgets. I just want to make the point that regulation and global budgets can be used to both constrain price growth and spending growth, but also used to support particularly smaller hospitals, rural hospitals that provide critical access and quality of care for their communities, as well as at being economic drivers for their communities. And supporting, essential services. And so without going into a lot of detail about it now, the model that David mentioned that we've developed for hospital global budgets does that. Basically, it differentiates between hospitals that are driving price growth and spending growth and those that are more vulnerable in the rural areas that have higher fixed costs, higher staffing costs, and it provides a more supportive and predictable environment and supports those fixed costs and standby costs that the smaller rural facilities face. And so anyway, that's just kind of a general comment that regulation and price regulation can be designed to both constrain costs where prices and spending's going up excessively, and also support access and financial viability for providers that are more vulnerable. So that's the point I want.
And flexibility, it sounds like.
Yeah.
There are local issues and solutions like what Shane's talking about. So
as well as this idea of uniformity of incentive. Which is very important in our very fragmented payment system we have now. Want to move away from that fragmentation and to provide predictability and uniformity for providers.
Yeah. Bob, I appreciate your standby capacity model. I think it makes a lot of sense. I think you're gonna want to tease out the actual costs, not just,
Yes.
you
Yes.
know,
Right.
the allowable cost models, they miss a
Yeah,
lot,
no,
right?
I know. Yeah, I was hearing your point on that. And the flexibility that you'd have by designing your own system is you could define what are reasonable costs. You wouldn't have to be held hostage to Medicare's definition of reasonable costs. So there are a lot of holes that could be plugged if you do your own system for the state.
Any final words from Mohammed? I see you. Great.
Oh no, I just wanted to add, a lot of the things that make care difficult for a lot of people is unnecessary stuff. For example, I think I remember one of our last meetings, we talked about pre-authorization and how it does not save cost, but it delays care, and that was a very good example. So I think if we can get rid of a lot of the things that don't make sense for the state and for care. I think there's a solution there, but I really appreciate the presentation. I've learned a lot.
Yeah, thank you all so much to our panelists. This has been a really fruitful conversation. Definitely, I think some more conversations to come, it sounds like, with Jane, and also perhaps having a presentation on global budgets and flexibilities and things like that. Staff will work on that and come back as we work to truly define how we want to make sure that rural hospital or rural providers are addressed in our universal system. So thank you all so much for your time and for the work you're doing and sharing the story that you shared, Shane. It's really different when you know it, when everybody knows everybody, and I think we have to always remember that it really brings home the value of healthcare work and what you're doing. So thank you. I'm going to turn it back over to our chair, and thank you all so much.
Thank you, Liz. Thank you to all our panelists. It was just a really fruitful conversation. We were here in the room nodding our heads and taking down tons of notes. So thank you for sharing your thoughts with us today. And thank you to all of our commissioners who were able to be here today for all the discussions and the directions. We appreciate our speakers for sharing their insights and helping us move forward thoughtfully in universal healthcare for Washington residents. And so the recording of this meeting will be posted shortly on the HCA's website for the commission. And our next meeting is April 17th, same time, 2 to 5. And I really look forward to seeing you all. But I'm sorry, Mohammed, did you still have?
I do. Just one quick point. I think because of the feedback that we get from public comments, I don't know if we can dedicate maybe 10 minutes in the beginning of the meeting to address some of those in real time.
That's a great idea, Mohammed.
Yeah.
Thank you. We're done then. Thank you, everybody. Have a great evening. Stay safe and warm. And if you're traveling in snow, be very careful. Take care.
Thank you, everyone.
Thanks all.